Imagine a pathogen that can just sit quietly in your system for 3 weeks.
Right. Completely silently.
Yeah. And in that time, you could fly from a remote clinic in Central Africa to like a massive international transit hub and then directly into JFK or Atlanta.
All without so much as a fever.
Exactly. And before we dive into how the global health system is frantically trying to intercept exactly that scenario today, I want to officially welcome you to the conversation.
It is great to be here.
Yeah, and if you are joining us for the first time, or if you're a regular, please make sure to like, subscribe, follow, and turn on that notification bell.
It really is the best way to make sure you never miss out when we unpack these deep dives together.
It really is. And before we get into the intersection of virology and global travel, we did promise to keep you updated on the Martin Stevens versus OpenAI matter.
We did, and there's some important nuance there.
Yeah, I want to be incredibly precise here because details really matter. First, this is explicitly not a lawsuit.
Right. Definitely not a lawsuit.
We are continuing to monitor the situation very closely, but we are currently in a voluntary quiet period.
And we should clarify that is at Martin's direct request.
Yes, exactly. We don't know if actual settlement discussions are underway right now, but, well, we're absolutely hoping for a settlement in the background.
Yeah, we are. And perhaps most importantly for everyone following this, we can report that the dead man switch has not been activated.
Thank goodness.
Right. That means Martin Stevens is physically and legally safe.
Yeah. And we will, of course, continue to update you as soon as that voluntary quiet period lifts.
Absolutely.
All right, so let's pivot to the primary mission of today's deep dive. We are looking at a rapidly evolving global health emergency.
Rapidly evolving is almost an understatement.
Yeah, seriously.
Yeah.
The CDC is actively mobilizing against a deadly Ebola outbreak in Central Africa. We have an infected American doctor, massive international travel restrictions that just dropped, and a domestic situation at the CDC that is, frankly, chaotic.
It's totally chaotic. We're essentially unpacking the intersection of virology, the actual mechanics of modern global travel, and some intense domestic tensions.
It's a scenario that fundamentally tests the architecture of our interconnected world,
Yeah, we are watching public health infrastructure operate under immense, almost contradictory pressures.
So let's start with the ground zero of this outbreak before we look at how it impacts you directly.
Good idea.
Over the weekend, the World Health Organization officially declared a public health emergency of international concern, or PHEIC.
Right, which is a massive legal and operational trigger.
Yeah, it really wakes up the international community. It's in response to an Ebola outbreak in the Democratic Republic of the Congo.
Specifically in the Ituri province.
Exactly, and cases have now officially crossed the border into Uganda. The numbers we are looking at are, they're severe.
Very severe.
We're talking over 100 suspected deaths and nearly 400 suspected cases in the DRC alone.
And we really have to consider the geography of the Ituri province. I mean, this is an incredibly challenging environment for a rapid epidemiological response.
Because of the terrain.
The terrain, yes, but also you're dealing with limited transportation infrastructure and, ongoing regional security concerns.
Wow, yeah, that complicates things.
Massively. A PHEIC declaration is necessary because containing an outbreak there isn't just about deploying doctors.
Right.
It requires a massive logistical and security apparatus just to get the diagnostics out into the field.
Which brings us to the human element currently at the center of the American response. Dr. Peter Stafford.
Right.
He is an American medical missionary working with the Surge Christian Mission. And he was exposed while treating patients at Nyankun Hospital in the DRC. He, along with, I think it was 6 other individuals who had high-risk exposures, has just been evacuated.
Yeah, and moving highly infectious patients from a remote hospital in the DRC, I mean, that requires an intense, highly coordinated interagency effort.
Between who?
Like the State Department. The State Department, the CDC, international partners. You need specialized aeromedical isolation units.
Okay, but here's where it gets really interesting. The State Department didn't evacuate Dr. Stafford and his team back to the United States.
No, they didn't.
They flew them to Germany. Now, I have to push back on this.
Okay, let's hear it.
If you have an American doctor infected with one of the most dangerous pathogens on Earth, why aren't we bringing him to a premier biocontainment facility in the U.S.?
Like Emory or Omaha.
Yeah, exactly. It seems totally counterintuitive to just leave him in Europe.
It seems that way on paper, definitely. But if we look at the physiology of hemorrhagic fevers, it actually makes complete sense.
Really? How so?
Well, when a patient is battling a virus that severely impacts vascular integrity, putting them in an aircraft cabin for a 14-hour transatlantic flight.
Oh, because of the pressure?
Exactly. It's incredibly dangerous.
Yeah.
The changes in cabin pressure, the vibration, the sheer duration of the flight,
Wow.
all of these drastically increase the risk of them crashing hemodynamically while in the air.
So it's less about the destination's passport and much more about the logistics of the human body in transit.
Precisely. Germany offers a significantly shorter flight time from Central Africa. You are basically taking a hub-and-spoke approach to aeromedical evacuation.
That makes a lot of sense.
And Germany has world-class Level 4 equivalent biocontainment facilities. Plus, they have proven existing experience in safely caring for Ebola patients from previous outbreaks.
Right, they've done this before.
Yeah. When every single hour counts and the patient's vascular system is literally under attack, you take the absolute shortest geographical path to the highest level of care.
Okay, well, let's talk about this specific biological threat Dr. Stafford and those patients are facing.
Good pivot.
Because this isn't just generic Ebola. We're talking about the Bundibugyo strain.
Yes, the Bundibugyo virus. It's a species of ortho-Ebola virus.
Okay.
And what makes this family of viruses so devastating is how they essentially blindfold the human immune system.
Blindfolded. How?
Well, they target dendritic cells.
And those are the immune system's early warning messengers, right?
Exactly. They are the messengers. By taking out the messengers first, the virus replicates unchecked.
So the body doesn't even know it's sick yet.
Right. And by the time the broader immune system realizes what's happening, it triggers a massive systemic overreaction.
Ah, cytokine storm.
Yes, a cytokine storm, which causes the severe symptoms we associate with the disease.
And the metrics on this specific strain are incredibly grim. I mean, based on prior outbreaks, we're looking at a 30 to 50% fatality rate.
It's very high.
But what really stands out in the source material is the medical arsenal, or, well, lack thereof.
Yeah, that's the scary part.
There are 0 FDA-approved vaccines and 0 specific antiviral treatments available for Bundibugyo.
None. And that lack of countermeasures completely changes the operational strategy.
I bet.
If we look at the epidemiological data, however, there is a distinct operational advantage here.
Okay, a silver lining. I like it.
Yeah, we are not dealing with the R-naught of a highly contagious airborne respiratory pathogen, like COVID.
Right, not like COVID. Bundibugyo requires direct contact with the bodily fluids of an infected person. And critically, a person is only infectious when they are actively showing symptoms.
Right, so there is no asymptomatic shedding phase where someone is just, silently breathing the virus onto a crowded subway car.
Exactly. The virus is biologically sequestered inside the host until the systemic symptoms begin.
So the fever, weakness, vomiting, diarrhea.
And in severe cases, bleeding.
Right.
Because there's no specific cure, our current medical defense relies entirely on proactive supportive care in high-level isolation.
Which basically means carefully managing fluids and electrolytes, maintaining oxygen levels, and just keeping the patient's biological systems functioning.
Giving their own immune system the time it needs to clear the virus.
Right. But I know the U.S. Biomedical Advanced Research and Development Authority, BARDA, is rushing to develop a monoclonal antibody therapy for this strain.
Yeah, they are. And monoclonal antibodies are essentially lab-engineered immune system assassins.
That sounds intense. They're designed to bind precisely to the surface proteins of the Bundibugyo virus. It neutralizes it and prevents it from entering host cells.
But until that therapy is developed, rigorously tested, and actually approved.
Our only weapons are supportive care and preventing the spread in the first place.
Okay, let's unpack this.
Yeah.
If you have a virus with an incubation period of between 2 and 21 days, basically a ticking time bomb with a completely silent alarm clock.
That's a great analogy.
Thanks. I mean, they could be walking around for 3 weeks feeling totally fine before it goes off.
Right.
So how does the United States prevent asymptomatic people from bringing it into the country? Because you can't just take their temperature at the border.
No, they won't have a fever yet.
Exactly.
This raises an important question about our border health architecture, and the answer just came down from CDC Acting Director Jay Bhattacharya.
Right, the new restrictions.
Yeah, the CDC has initiated a sweeping, highly targeted border health response using a Title 42 order.
And this is effective immediately, right?
Effective immediately and lasting for at least 30 days. The CDC is suspending entry into the U.S. for non-U.S. passport holders who have been in the DRC, Uganda, or South Sudan within the previous 21 days.
Okay, just to be clear on the mechanics of that,
Yeah.
it does not matter what country their passport is from.
Nope.
If their travel history touches those 3 nations in the last 3 weeks, they are barred from entry.
Completely
I
barred.
mean, there are exemptions, of course.
Yeah.
U.S. citizens, U.S. nationals, lawful permanent residents, and military personnel are exempt.
Though they are subject to enhanced public health screening and traveler monitoring.
Right. But I have to ask, do international travel bans actually work?
Well,
Because historically, infectious disease experts have argued that travel bans just incentivize people to hide their travel history and route through third-party countries, making them way harder to track.
that is the classic epidemiological debate. A travel ban is almost never an impenetrable shield.
Right, people will reroute.
Exactly. But what's fascinating here is the underlying rationale of this specific Title 42 order. It is entirely about resource allocation. We have to look at the realities of modern global aviation, which operates on a massive hub-and-spoke model.
Right. A person can leave a remote health zone in the DRC, get to a regional airport, and board a flight to a massive international transit hub.
Like Addis Ababa, Doha, Dubai, or Istanbul.
Yeah, and from those hubs, they can be on a direct flight to major U.S. gateways like JFK, Atlanta, or LAX,
And that entire journey can easily happen within 24 to 48 hours.
which is well within that 21-day silent incubation window.
Precisely. So if the CDC allows everyone who has been in the hot zone into the U.S., the volume of individuals requiring daily 21-day monitoring becomes mathematically impossible to manage.
Because contact tracing requires immense manpower.
Immense. By banning non-citizens who have been in the affected areas, the CDC isn't claiming they will stop every single exposed person.
They're intentionally shrinking the haystack.
Exactly. They're reducing the sheer volume of high-risk arrivals from potentially thousands down to dozens.
Wow. So it's a numbers game. By restricting entry, they protect their finite resources, like laboratory testing, quarantine management, and public health personnel.
Allowing them to concentrate their full attention entirely on monitoring returning Americans and permanent residents.
And coordinating that requires a massive, invisible net.
Oh, absolutely.
The CDC has to work with international airlines and port of entry officials to track complex, multi-leg itineraries that might obscure a traveler's original point of departure.
And real-world events are about to stress test that net.
Oh yeah, we have a massive logistical complication looming right around the corner.
The World Cup?
Yep. Houston is slated to serve as the host site for the DRC national team for the World Cup starting next month.
If we connect this to the bigger picture, it perfectly illustrates how deeply intertwined global events, economics, and health security truly are.
Definitely.
The U.S. government is having to actively work on final security and public health plans for World Cup athletes, while this Title 42 order is actively barring entry from their home country.
That's wild. It requires diplomatic and medical exemptions to be managed on a hyper-accelerated timeline.
Yeah, the pressure is on.
So we have the CDC executing this massive international medical net, coordinating with airlines globally, and trying to catch a deadly virus at the border.
Doing their job.
But what happens when the very people tasked with defending the country are under physical attack at their own headquarters?
Yeah, we have to talk about the domestic battleground.
It is a stark, almost unbelievable contrast.
It really is. While the agency is trying to manage a highly complex global health emergency, all CDC campuses nationwide, including the main headquarters in Atlanta, were closed on Monday due to a deadly shooting.
And we want to report this neutrally based on the facts provided by local authorities.
Right.
The shooter was reportedly motivated by a deep ill will toward the CDC, specifically an intense hatred of vaccines following an apparent bad reaction to a COVID-19 vaccine.
And the physical damage to the facility is severe.
Yeah. We are talking about shattered glass from bullets on multiple buildings along Clifton Road in DeKalb County.
Multiple buildings.
Building locks had to be physically broken by law enforcement to clear the structures and ensure there were no secondary threats.
As a result, the very scientists, epidemiologists, and logistical experts managing this Ebola response,
Right.
they are being forced to coordinate this global effort virtually from their kitchen tables and home offices.
The union representing CDC employees has stepped in, demanding a sensible, safe return-to-work plan.
And you really can't blame them.
Not at all.
Yeah.
They're pointing out the immense psychological toll on scientists who feel increasingly under threat from a highly politicized domestic landscape.
Simply for trying to execute public health mandates.
It creates an incredibly tense operational environment.
You have professionals analyzing epidemiological data from Central Africa while simultaneously waiting for their own shattered office windows to be replaced.
Just surreal.
But what is truly remarkable is that despite the physical damage and virtual operations, the actual scientific readiness of the CDC and their partner hospitals remains incredibly sharp.
Which brings us to a perfect example of that readiness. In the midst of all this chaos, we just saw a massive, high-stakes false alarm right in the CDC's backyard at Emory University Hospital.
The situation involving the MV Hondius cruise ship.
Right. There was an outbreak of Andes virus, which is a type of hantavirus on that cruise ship.
And it had already claimed 3 lives.
Yeah. Over the weekend, 2 passengers from that ship were flown into Atlanta and rushed to Emory University Hospital's Serious Communicable Diseases Unit.
And this wasn't a quiet admittance.
No. We are talking television helicopters hovering overhead, a convoy of ambulances, and medical staff in full positive pressure protective hoods and gowns.
Emory's biocontainment unit is essentially an engineered fortress built exactly for scenarios like this, and specifically for pathogens like Ebola.
It's not just a regular isolated hospital room.
Far from it. These are intensive care units designed with profound negative air pressure, meaning air can flow in, but it can never flow out without passing through massive industrial HEPA filters.
The mechanics of it are wild. I was reading that even the solid waste from the patient's room doesn't enter the normal sewer system.
Oh, definitely not.
It is sanitized with highly pressurized steam in specialized autoclaves and then incinerated.
That level of containment is necessary because you are operating under the assumption that the pathogen is lethal and highly transmissible until proven otherwise.
And in this case, it was proven otherwise.
Thankfully.
The passengers turned out to be negative for the hantavirus. They were safely discharged.
Great news.
The CDC director actually released a statement noting that the threat of hantavirus spreading in the U.S. is extremely low, and none of the 41 Americans currently being monitored from that ship have confirmed cases.
So it was entirely a false alarm.
Entirely. But from an operational standpoint, it was a flawless practice run for the Ebola threat.
It proves that the physical infrastructure, the biocontainment units, the aeromedical transport, the infection control protocols, they work flawlessly.
They really do.
But it also highlights the immense, almost contradictory pressures on our public health institutions right now.
So what does this all mean when we put the pieces together?
Well, if we connect this to the bigger picture, in a single week, you have the CDC simultaneously trying to manage a deadly global Ebola outbreak, coordinate complex international travel bans through a Title 42 order, evaluate suspected hemorrhagic fever patients in high-security biocontainment units, and somehow protect its own workforce from domestic violence.
That's unbelievable.
The physical science is sound, but the social and political infrastructure surrounding public health is critically fractured.
That is a lot of heavy information to process, I know.
Huh?
But we want to leave you with a clear summary and some much-needed reassurance.
Always important.
Despite the dramatic headlines, the evacuations to Germany, the Title 42 travel bans, the television helicopters hovering over Emory, the immediate risk of the Bundibugyo Ebola virus to the general U.S. public remains extremely low.
The biological mechanics of the virus are entirely in our favor when it comes to domestic containment.
Right.
It is not airborne. Transmission requires direct physical contact with bodily fluids from a symptomatic person, and our healthcare facilities are highly trained to identify and isolate those specific symptoms.
Furthermore, the Title 42 travel restrictions, by reducing that immense haystack of international arrivals, are functioning exactly as intended to shield our borders.
It allows contact tracers to focus entirely on the highest risk individuals.
The global net is deployed, and it is holding.
The system is strained, undoubtedly, but it is actively working to keep the threat isolated.
But before we go, we want to leave you with a final lingering question to ponder on your own.
Okay, let's hear it.
We've talked extensively about the mechanics of our global travel network. Given that a highly lethal virus can replicate silently inside a human host for up to 21 days,
Right.
and modern aviation allows someone to transit through major international hubs and cross the globe in less than 24 hours.
Yes.
Are our international travel hubs fundamentally incompatible with containing modern biological outbreaks?
Oh, wow.
Could a novel pathogen eventually use our own logistical interconnectedness as its ultimate weapon, utilizing our hub-and-spoke transit networks to spread globally before we even realize the biological alarm has been tripped?
It is the exact scenario that public health officials lose sleep over every single night. And it's why monitoring this current outbreak is so vital.
It really is. Well, thank you so much for joining us and exploring the intricate details of this deep dive.
It's been a great conversation.
As always, if you found this conversation valuable and want to stay informed on the mechanics behind the headlines, please remember to like, subscribe, follow, and turn on that notification bell.
We rely on you to keep this conversation going.
Stay curious, stay informed, and we'll see you right here for the next one.